Hello, lovely viewers. Welcome back. Today, we're talking about chickenpox. But before we delve into the details, if you haven't already, make sure to hit that subscribe button and ring the notification bell, so you never miss out on our latest health updates. Alright, let's get started. Chickenpox is caused by Varicella zoster virus, VZV. They persist in ganglion cells for the lifespan of the host. Part of the alpha herpes viruses group. Acquired by the inhalation of airborne respiratory droplets, direct skin contact with vesicle fluid, and transplacental. Exposed should be considered infectious from 8 to 21 days post-exposure, or 8 to 28 days if they have received Varicella zoster immunoglobulin. Countries with tropical and semi-tropical climates have a higher incidence of adult chickenpox than do countries with a temperate climate. After the initial infection, enter dorsal root ganglia or trigeminal ganglia to become latent. Reactivation of infection results in localized herpes zoster, shingles. In children, zoster can cross dermatomes, but is usually milder than in adults, and post-herpetic neuralgia is less common. An infected person is infectious from 2 days before the appearance of the rash until the vesicles are crusted over. Clinically when presenting. Initially present with lethargy, anorexia, malaise, and low-grade fever followed by eruption of a rash over next 3 to 5 days. About the rash, lesions may be found in all stages of development and healing in affected sites. Small, erythematous macules appear on the scalp, face, trunk, palms, soles, mucous membranes, and proximal limbs, which progress to papules, clear vesicles, pustules, ulceration, and subsequent crust formation. Lesions are surrounded by an erythema, usually fully crusted over by 10 days. Intense pruritus commonly accompanies the vesicular stage of the rash. Vaccination can cause a rash, typically 1 to 3 weeks later. Moving on to the complications. Complications include bacterial superinfection, particularly group A Streptococcus and S. aureus, leading to impetigo, cellulitis, erysipelas, pneumonia, encephalitis, hepatitis, arthritis, Guillain-Barré syndrome, and Reye syndrome. Hemorrhagic complications include thrombocytopenia and purpura. Disseminated primary varicella infection is seen in the immunocompromised or adult populations. Complications are more common in premature neonates and neonates exposed before 7 days of age, unimmunized adolescents, and immunocompromised children. Children at risk of complications are malignancy, receiving chemotherapy or high-dose steroids, and immunodeficiency. Primary maternal chickenpox infection in early to mid-pregnancy risk of causing congenital varicella syndrome, which is characterized by limb hypoplasia, muscular atrophy, skin scarring, cortical atrophy, microcephaly, cataract formation, and rudimentary digits. Peripartum infection when the mother experiences the onset of chickenpox, /5D before delivery or within 2D after delivery often results in severe disseminated varicella. Chickenpox is a clinical diagnosis. No investigations are routinely required. In neonates or immunocompromised children, a vesicular swab for PCR may help confirm the diagnosis. Other methods of investigation include: zinc smear of vesicular fluid shows multinucleated giant cells and epithelial cells with eosinophilic intranuclear inclusion bodies. Serology. Primary varicella infection in a healthy child is a rather benign disease that requires symptomatic therapy only. Oral acyclovir should be considered for healthy persons at increased risk of severe varicella infections. For pruritus, apply calamine lotion, cut nails, antihistamines. In adults, acyclovir therapy is given within 24 hours of the onset of symptoms. Intravenous acyclovir therapy is recommended for patients who are immunosuppressed or immunocompromised. Varicella zoster immune globulin is indicated for use in highly susceptible, such as newborns, less than 1 year, premature infants, and pregnant women, and varicella-exposed immunocompromised or immunosuppressed populations. Given within 10 days of exposure can modify the course of the disease, but does not prevent it. A live attenuated vaccine is available. But breakthrough varicella can occur with milder and atypical presentations. Moving on with the management guidelines as stated in the RCH Guidelines. In immunocompetent children 1 week old and less than 12 years old, no specific therapy is indicated. Avoid aspirin due to increased susceptibility to Rye syndrome and NSAIDs due to increased risk of invasive gas. Treat bacterial superinfection and underlying eczema. Children must be kept out of daycare centers, kindergartens, and schools until all lesions have healed. Avoid hospitalization where possible. If required, isolation and contact precautions apply. Notifiable infection in some states. Pregnant women who have had contact with chickenpox should be reviewed within 24 hours, regardless of the stage of pregnancy. Use 4-acyclovir in premature neonates and term neonates less than 7 days of age. Children at risk of complications or with complications. Use oral acyclovir in unvaccinated child age greater than 12 years. Severe eczema. Chronic pulmonary disease. Children on salicylate therapy, oral steroid therapy. Secondary cases in household contacts, as these are usually more severe, when managing contacts as recommended. Age 1 month to 1 year, if the child is not at risk of complications, observation is recommended. If at risk of complications, consider VZIG. Age greater than 1 year, if the child presents within 5 days of exposure and no contraindications to the vaccine, give the varicella vaccine. There is no harm in having a second dose of the vaccine if immunization status is uncertain or parents request this. If children are unable to have the vaccine and are at risk of complications, consider varicella-zoster immune globulin. Immunodeficient contacts should receive varicella-zoster immune globulin, and their household contacts should receive varicella vaccine if they are susceptible to disease. Treatment and prevention of neonatal varicella infection. If a term neonate 1 week of age develops a rash consistent with chicken pox, they should be investigated and treated with 4-acyclovir. Neonates who have had exposure to varicella and subsequently become unwell, regardless of whether they received immunoglobulin, should be commenced on 4-acyclovir. If maternal serology is unknown, assume maternal antibodies absent. The table below as mentioned in the RCH Guidelines shows the management of a neonate exposed to VZV depends on gestational age, the mother's serologic status, and the timing of the exposure. Isolate a neonate who has had contact with varicella for the first 21 days of life, or 28 days if immunoglobulin has been given. If parents have been in contact with varicella, their immunity should be tested. If immune, they can attend the newborn nursery as normal. Exposed people shouldn't be allowed to enter places with susceptible individuals during the infectious period, 8 to 21 days. Maternal varicella is not a contraindication to breastfeeding. If the mother has lesions on her breasts, they should be covered with gauze and occlusive dressing. The National Immunization Program currently includes a single dose of a varicella-containing vaccine, MMRV, at 18 months of age. The Australian Technical Advisory Group on Immunisation, ATAGI, recommends that adolescents greater than or equal to 14 years of age receive 2 doses of varicella vaccine, at least 4 weeks apart. Alright, that wraps up our discussion on chickenpox. If you found this video helpful, don't forget to hit the like button and share it with your friends and family. Subscribe to our channel for more informative content on various health topics. Stay informed, stay healthy, and until next time, take care.